spleen complications do not affect complement. I know complement is challenging. I would try to read it once or twice and do some questions specifically in this. But overall, if you see the answer choices, because again, we're test takers, right? We're trying to teach you guys how to pass the test. Read a case like this. You knew a sickle cell. Think to yourself, why did people only chose 54% here? Obviously, deficiency, clearance of bacteremia, functional asplenia. What does this mean here, guys? It means that typically when a kid has sickle cell, their spleen just stops giving up after some time. All right, it says right here, in most children with poor sickle cell disease, the spleen gets infarcted over and over and over again, and eventually it loses function. It's still there, it just loses. By 4 years old, the latest, there's no function. If there's no function of spleen, what happens? This happens here. So see, this explanation is pretty good, because then if you go further, it says, well, IgM production is decreased, which leads to ineffective complement activation. And that's why maybe they see complement production. It's actually the opposite. And thus, ineffective complement activation, thus impaired opsonization, which you guys all need to know what this is, of bacteria. That's why, since this is the body's defense against bacteria that has capsules around it, the risk of infection with such pathogens is increased. So anything that has a capsule, it will have a problem if you have no spleen, right? That's why strategies to prevent infection in patients with SCD, you give vaccine, and daily prophylactic penicillin from 3 months until 5 years old. This is good information here, guys. Now, if any of this terminology goes above your head, that's a sign that you have to know the terms, because they're going to ask you about IgM, IgG, about opsonization. That's why micro is very, very important, very big, okay? And taking time reviewing this, it can go really, really further in your career instead of USMLE Step. Because if you remember this, what we did here before, you know, I'm gonna do, watch, ready? CGD, here we go, CGD. There's only a few. CGD. Actually, here we go, respiratory burst. This is what I want to show you. Even though we don't cover a lot of it, you know we've seen G6PD deficiency. We've talked about catalases before, NADPS oxidases. This is CGD. This is important to at least review once or twice. They love asking questions about respiratory burst. They just do, because it's very, very important. And this pulls into place, you know, about NADPH when it comes to biochemistry. We have pathways like H&P shunt that makes NADPH. So you realize if certain pathways aren't working, they're not making certain things that we need, like TCA cycle. Think about the Krebs cycle, TCA. We're making ATP, GTP, FAD, wow, NADH. If that cycle doesn't work, all those things we make that we use for other pathways don't exist. That's a problem. So when you cover in biochem, which I know a lot of you aren't really love with, but we have to be good in it, or at least take the test and pass. The videos that I have in the QBank really push vitamins, deficiencies, toxicities, pathways. I try to do my best to bring it all together for you to show you how to connect, because it is very important, very, very important, okay? When you do immunology, for example, again, here, check this out. Check this out. Let's go down a second. Hold on a second. It's right here. When we did the congenital immune deficiencies, remember, we had the B cell disorders. There's 3 of them. We have the T cells, there's 4 of them here. Then the other 4 for B and T cell. And the last 3, here it is, LAD, CHS, and CGD. Defect in NADPH oxidase. It's X-linked, most common form. They love throwing these 2 tests